So ladies and gentlemen, my name is Sharon Whiteman, and I'm currently president of the Lyme Disease Association of Australia. It's a labor of love. I'm fiercely driven by injustice. And when I first got sick and then learned about what's happening in Australia and the lack of medical care, I thought somebody's got to do something. And, you know, if nobody stands up, then it doesn't get done, does it? So 10 years plus later, we're still fighting the good fight here on behalf of all of you and your loved ones who are sick and suffering from Lyme and associated diseases in Australia. We're very privileged today to have Dr. Robert Bransfield. He's a graduate of Rutgers College and George Washington University School of Medicine. He completed his psychiatric residency training at Sheppard and Enoch Pratt Hospital. He's board certified by the American Board of Psychiatry and Neurology in Psychiatry, and is a distinguished life fellow of the American Psychiatric Association. Dr. Bransfield's primary activity is an office-based private practice of psychiatry. In addition, Dr. Bransfield is the past president of ELADS, the International Lyme and Associated Diseases Education Foundation, and the New Jersey Psychiatric Association. He has held a number of administrative positions with organizations involved with health, mental health, and community-related activities. He is a clinical associate professor of psychiatry at Rutgers, Robert Wood Johnson Medical School. Dr. Bransfield has authored and co-authored a number of publications in peer-reviewed literature, other medical publications and books, and has been active in political advocacy on an international, national, state, and local level. Professor Bransfield, we're so blessed to have you here. Thank you so much. This is the first of a short series for our May Lyme activities in 2022. So we're very privileged to have you. Thank you.
Thank you, Sharon. I'm glad you invited me, and I'm happy to be here. And it's I was in Australia a few years ago, giving a couple talks there, and it's nice to be able to talk in Australia without the long plane flight.
Yeah, Zoom's changed the world, hasn't it?
Yes, it has.
One good thing. So I thought we'd start with just a little bit about your background and your career, and then how did you come to specialize in Lyme and mental health, such a difficult subject and topic and situation?
Well, I was always interested in what truly causes mental illness. And people in my age bracket, we were taught basically the psychoanalytic theories because that's what predominated at that time. But it seemed like that didn't answer everything. So it seemed to there had to be something more than that. But at that time, we didn't have brain imaging. We really just saw the brain as a black box that was mysterious, and you had skull x-rays, which told us nothing. We didn't have MRIs, CAT scans, PET scans, any of that. So there were theories at that time of what was called the slow virus, that maybe infections played a role. And we knew that syphilis played a big role in causing mental illness. And maybe there were other infections that played a role. So I was always looking at what truly causes mental illness. Now, looking back, I'm sure I was seeing what we call Lyme patients, even in my residency, but I didn't realize it at the time. And in an area where I practice in New Jersey, there is a lot of Lyme disease, and I would be referred patients, and they were like from infectious disease doctors, and they were considered cured because they had a month of antibiotics, but they had all these psych symptoms. And I tried everything to try to treat them, and it seemed like the only thing that would work would be giving them more antibiotics, and then they would improve. So I would say, well, who can I send these people to? And I contacted Brian Fallon, and he was also involved. And we're looking back over 30 years ago that I was doing that. And there were so many patients that I just couldn't refer them to other people. So I had to figure it out myself. And I did specialize a lot with treatment-resistant psychiatric illness. Basically, the patients that wouldn't be treated easily by the current treatments that we use. And a lot of these patients ended up having Lyme disease. And so I was forced to figure it out myself and try to analyze it and research it. I've done a number of research projects and published it in different journal articles with my findings. And the more I looked at it, the more aware I became that this has a lot to do with what makes mental illness occur. Now, it also, when you look at it theoretically, there's a discipline called Darwinian medicine, or evolutionary concepts. And from that standpoint, you think, why does disease occur at all since evolution is so perfect? And when you look at that, infectious disease is a big part of what causes chronic disease. And even the CDC, NIH recognize that many chronic diseases are related to infectious disease. Now, the problem is that in medicine, there's been a tendency towards authoritarianism that's developed, that's inhibited free thought, I think, and that's happened with some of these big healthcare systems that evolved. And there's also a tendency towards what we call silo mentality. And silo mentality is where you just stay within your discipline and that's it. But you can't figure this out by silo mentality. You have to go outside your area. And the father of American medicine, Sir William Osler, who wasn't really American, he was Canadian, and he based, like yourself, he basically said to know syphilis is to know medicine, and that he recognized the complexity of it. Now, syphilis is a simple spirochete compared to Borrelia, the Lyme spirochete. It's much more complicated. The syphilis has 22 genes, whereas Borrelia has 132, has a lot more variability. It can evolve within the body. It's much more complicated. So to figure out Borrelia, you have to know a lot more in medicine. You have to know entomology, you have to know ecology, you have to know psychiatry, you have to know immunology, you have to know infectious disease, you have to know politics and many, many more facets of medicine. You can't just stay in one discipline. Now, if we look back at the history of it, how it's evolved, it was first discovered in Germany in the early 1900s. And there was a lot of work with Borrelia then, trying to understand it, but then World War I came and that killed that research. And a lot of people then forgot about that. And then it was rediscovered. Now, it was rediscovered in different ways, but one way it was rediscovered was in 1971 by Dr. Scrimeni. And he was the first to describe it really in America. And then there was an outbreak in Lyme, Connecticut, and then it became popularized. Now, when that was researched, it was researched by a rheumatologist. And then there was a certain power struggle to take ownership of the disease. And that's continued since. And there's been a narrow definition of it based on early inaccuracies, that it was basically an arthritic condition. But the disease definition really needed to be expanded beyond that. So there's been a lot of obstacles to forward momentum, similar somewhat to what happened with HIV, with AIDS. And look at what happened with ulcers, trying to understand ulcers and seeing the infectious disease component, how people thinking outside the box were faulted severely because it didn't go with the existing dogma. And you do see when things don't make sense, think of power, money, and ego, and then you get the answer. And so dogma has no place in science. By definition, everything in science is subject to question, whereas dogma is authoritarian and rigid. And we can't have that in science. A big part of medicine is science. So we have to be open to new ideas and incorporate them. And when we look at chronic diseases and the toll they take on our world, we really have to be open to any new idea that might improve our effectiveness in treating diseases. And that's particularly true in psychiatry. Now, I think a problem, particularly in understanding how these infections cause mental illness, there's a big gap between infectious disease and psychiatry. And if you look at a lot of your thought leaders in infectious disease, many of them may have had a 1-month rotation in a state hospital 40 years ago, and that's their knowledge of psychiatry. And they haven't really expanded much since then. And psychiatrists, some don't have much of a knowledge in infectious disease. So there's a gap but we need to bridge that gap so that there's better communication between the two disciplines that really aren't as far apart as we realize. And I really think a lot of mental illness is really related to infections causing immune reactions, causing impairments that alter how brain circuits work, causing mental illness. And there are really thousands of journal articles supporting that with different infections. Now we can nitpick about what infection it is, but the whole concept that it's infections and probably multiple interactive co-infections is a better term that's used, similar to the AIDS concept. It's just not one infection. So we have this interactive co-infection, and these are localized in different areas where you see more local infectious diseases that play a role. But I think globally, you see infections causing mental illness around the world. And Borrelia is found in 7 continents. It's found in Antarctica. If it's found in Antarctica, I think it's probably in Australia. And although it may be a different strain than the strain that we use as our reference point for Lyme disease. Now, the strain that's, unfortunately, there's this narrow definition of Lyme disease. And the narrow definition was good for people trying to make money on test kits and vaccines, because you have to have a precise definition to use a reference point for that kind of research. But the reference point used is the B31 strain from Shelter Island, New York, that was grown in the laboratory. So if you're infected with the B31 laboratory strain of Borrelia burgdorferi sensu stricto, then it'll show positive if you had an infection, let's say a month or 2 ago. But otherwise, it may not be a good reference point. But a lot of people have rigidly had this as the way to define a disease, this laboratory criteria, and there's a lot of flaws with the laboratory criteria. So in psychiatry, we make a clinical diagnosis. We make a total clinical diagnosis. You have to look at history. You have to do review of systems. You have to do mental status. You have to look at everything. What were you like before this began? What are you like now? What are all the different symptoms you have? And that's how you do the diagnosis. You don't use a flawed lab test as your reference point. So we use the word Lyme disease because that's what people know. It really isn't an accurate term. There's a lot of different words that are used to describe this, but it's really chronic infections associated with causing multi-system illness. And when you have an infection that provokes the immune system, it doesn't just affect one part of the body, it affects the whole body. So the more you see what we call polymorbidity, comorbidity, more than one illness, the more likely it's a illness affecting the entire system, such as an infection causing an immune reaction, and that immune reaction causes problems with GI tract, with brain, with nervous system, with many different parts of the body. So I think that's the way we have to look at it.
Yeah, there's the history sort of brings us down, doesn't it? So you've mentioned in there the concept of a multi-system illness. And I was looking through some of your papers this morning to refresh my Lyme memory. And, you know, one of my favorite quotes from you is the onset of a multi-system illness is rarely, if ever, associated with a psychogenic etiology. So can you expand on that, Dr. Bransfield, and just understanding, you know, psychiatric is even the new clinical pathway that you've assisted with us early, the debilitating symptom complexes attributed to ticks is patient blaming in itself. It's sort of like it's insinuating that there's a psychiatric origin, that these people have a tick bite and then assume that they're sick because of it. Can you comment on that multi-system? I've been helping patients in Australia, like most people who have some level of recovery in Australia end up helping other people go forward. And I made that decision, you know, in 2010 that we had to do something, we had to do it together. And I've had so many people I've helped, you know, that end up with psychiatric labels or, and that one patient in particular I've been helping for the last 3 years. She's went to the US, got way better, came back and regressed without us being able to replicate the treatment she had there. And she's been going to multiple specialists. So she's got a neuropsych aspect, she's got infectious aspect, obviously. She's got an immunological problem. And but when we go to those different specialists, none of them will work together in Australia. They want to silo their diagnosis and just this or just that. We can't get them to collaborate internationally or locally. So what is it in medicine that you think brings that situation up for Lyme patients?
Well, I think part is how medicine's evolved to super specialization. So we do have the silo mentality, and that's been unfortunate. And I think also this whole idea where it's psychogenic, that whole idea. And also I'd like to address the whole idea of multi-system illness. Right?
Thank you.
So maybe I'll start with multi-system illness for a minute. What we're realizing now, if we look at diseases like schizophrenia and bipolar, they're multi-system illnesses. And even though we pay more attention as psychiatrists to the psychiatric part, they're multi-system. I'll give an example. Your average schizophrenic patient dies 19 years sooner than the average person. And it's not just because they have a mental illness and they might be at risk for suicide or something related to not taking good care of themselves, but they also have a metabolic component to that illness. So many schizophrenic patients have diabetes, they have high cardiovascular risk factors. So whatever happens to them, they have some probably pre-existing genetic or otherwise susceptibility. They're exposed to some environmental trigger, and that causes some reaction, including some immune reactions, so that you get diseases of both the brain and the body. We see the same thing with bipolar disease, where bipolar patients die an average of 9 years sooner, often from illnesses that are general medical, not psychiatric. So, and again, they also have metabolic risk issues and also cardiovascular risk issues. So you can't really isolate the brain from the body. Diseases aren't consolidated really into one part of the body. They impact the entire body. The body's interconnected. Now, the other is the concept of like all in your head. And I think the way it used to be is if you can't figure out what an illness is, then it's psychogenic. It's all in your head. And now you can wash your hands of it and you don't have to think it through. And what we're dealing with now are the diseases that are hard to understand. So the diseases that are easy to figure out have already been figured out. So if, for instance, some of those diseases, there's a clear trigger, there's a clear pathophysiology and clear symptoms that are replicated from one person to the next. Those are easy to figure out. But what we're stuck with now that we can't figure out are diseases that have multiple contributors, multiple pathological pathways, and present in multiple ways in different individuals. There are too many variables for people to understand, so people get lost. They throw up their hands and then they say, well, let's just call it psychogenic, then we can wash our hands of it. Now, if you look at what is psychogenic, there is something we can think of as psychosomatic. And true psychosomatic illness is where, let's say you get stress and when you're under stress, maybe you get diarrhea or maybe you get headaches or maybe you get sweating or your face turns red or you get palpitations. Now, those are lifelong traits that someone has since childhood. And if you have that trait your whole life, that's how you show stress in your body, particularly if you internalize the stress. If you're antisocial, you externalize the stress and people around you suffer. But if you keep things in, then you may show symptoms, but it's always the same. And you have it since childhood, you have it your whole life. But if all of a sudden you get a symptom in adulthood, you can't call that psychosomatic, the symptom you've never had before. That's not psychosomatic. And even psychosomatic conditions are not totally psychosomatic. A good example is irritable bowel. And that's probably one of the most common psychosomatic conditions. But irritable bowel also has to do with being sensitive to gluten or dairy products, so that's a piece of it, whereas emotional distress is another piece. It's the additive of those things. So there's a psychiatric component, but there's also a physical component. So there's both there. So now psychosomatic conditions, though, are never multi-system. It just doesn't happen that way. Or if they are, you know it since childhood that maybe they do have an autonomic dysautonomia that they've had their whole life. Although the question is, why did they have in the first place? Why, when we look at evolution, and this goes back to Darwinian medicine, when you look at how perfect evolution is, why is there disease at all? And one theory is competing organisms that damage our regulatory pathways. And the brain in a healthy state, it's like the gear shift in a car where it adapts to road conditions. It adapts to life conditions. So you should be fearful when there's danger. You should have mood elevation when there's opportunity, and you should have the mental flexibility to shift as things change. But when you have injury to those circuits, then you're fearful where there's no danger. So then all these circuits that we have with obsessiveness or depression plays a role. It's a healthy response of futility. But when it's extreme, when it's exaggerated, it's that injury to that circuit that's normally adaptive that then reaches a pathological degree. And now it impedes adaptation instead of facilitating it. So that's what seems to happen. So we see when we look at, let's say, mental illnesses, and we do studies with genes now. And a good example is we take someone who's, let's say, gets ill with depression or some other illness, and then we look at what their gene expression is. Then they're treated, and then they improve. And then we look at how the genes change. And we see that different genes upregulate and downregulate, and that correlates with the degree of illness. Most of those genes are immune system genes, not really neurotransmitter genes. So the immune system plays a big role in communication within the brain. And there's two parallel pathways of communication in the brain. There's the neurotransmitters and immune transmitters. And so you can't separate the immune system in the body from the immune system in the brain. There's a crossover. So when you have a condition that causes some immune disturbance, and infections is the most common thing that causes immune disturbance. There's other things too, allergies, toxins, etc. But the most common thing that causes an immune alteration is an infection, particularly a chronic infection that may be persistent and may be something that goes under the radar, stealth infection, we might call it. So that can cause a chronic provocation of the immune system. Now, when you get, let's say, an infection, let's say somebody sneezes on you, now you get early inflammation, then you get adaptive immunity, and now you're fine, and it's over and it's done. But with these chronic low-grade infections, that doesn't happen. Instead, you get early inflammation. You never quite get adaptive immunity. So inflammation persists, and you may get autoimmunity that causes a different cluster of symptoms. So then you get this mix of inflammation, autoimmune symptoms that just keep going. And it doesn't just affect the brain, it affects the body as well. Now, and so when we think that way, we have new opportunities to help people. We have new opportunities to prevent illness and death and disability. And this is a wonderful opportunity. So why close our mind to it? However, some people, there's some people that are, there's an innovation curve where there's the early adapters and the laggards and the late adapters. And that's just the way it is, that some people, now some of the people that are early adapters maybe adapt too early before it's proven enough. Yeah. And then there's the laggards, but then there's the maybe the silent majority in the middle, that the later adapters that kind of tip the balance. So that's true with any new idea. But I think this whole idea that looking at the immune system helps us understand, and infections helps us understand mental illness, and looking at these as multi-system illness that they are, I think that's well proven. There are literally thousands of journal articles showing infections cause mental illness. There's over 400 journal articles that tick-borne diseases cause mental illnesses. and it's well proven. And why would that only happen in other continents, but not in Australia? That doesn't exactly make sense. And invariably, when you see this, you see these other impacts other systems as well. So I think it's a whole new area, but people aren't used to thinking that way. And it takes a while for people to broaden their minds and to be open. Humility is a very good trait in medicine, and arrogance is a very dangerous trait in medicine. And unfortunately, we see a lot of arrogance with some people. And there's a saying, there's known knowns and known unknowns, but the problem is unknown unknowns, that which you don't know that you don't know. Yeah. And you have to, better you undersell, how much you know and be open to new ideas than to be overly arrogant and to think you know more than you do, and to impose that on other people that maybe are at the front line of medicine who really know more. Mm-hmm. If you need a heart transplant, who would you ask? Would you ask a government bureaucrat, or would you ask a cardiologist who does, or a heart surgeon who does surgery every day? Who is the expert there? And I would ask the heart surgeon, and I think anybody would say the same thing. Why don't we do the same thing with these infections? Why don't we ask the frontline doctors, the family doctors, the experts? The people that are bureaucrats, that are epidemiologists, that are bench scientists who never treat a single patient. They are calling shots that are outside their areas of competency and expertise. We have to look at what's observed. That's if I go back to Henry Ford when he invented the Model T, what he did to try to perfect the Model T was he went to junkyards. And in going to junkyards, he looked what went wrong with my cars. And he learned from looking at the front line or repair shops. A good general goes to the front lines to see what's going on here. They don't sit in a posh office and call the shots based on some computer algorithm. So we have to look at putting more credibility into clinical observation, into basics in medicine that have been there since Hippocrates, and listen very carefully to patients and have that as our starting point instead of some pre-existing belief that can be wrong and can be a silo mentality that closes out information that is corrective.
Absolutely. One of the quotes I highlighted today of yours was, the list of conditions considered to have a purely psychosomatic basis keeps shrinking as scientific knowledge advances. So I think, we can only hope, like in Australia, what most recently the consultation with frontline patients and frontline doctors was done very thoroughly by a consultant company, and then completely thoroughly they ignored everything and went ahead, creating a clinical pathway that looked unlike anything at the frontline information they received in those consultations. So it was, ultimately a bureaucratic box ticking exercise saying that we consulted. They didn't listen to one single thing that the front line.
I saw the same thing with the IDSA guidelines. And in order to do grade criteria, you have to elicit feedback. And they elicited feedback. I wrote a journal article on feedback. What I said to them, I converted to a journal article. And they did not, I didn't see where they changed a single word in their guidelines based on the feedback. They just did it so they said they could do it. And they totally ignored everything because they had a predetermined idea of what they were going to say, and really did not have listened to any feedback. So it's one thing to get it, so you're going through the motions, but you're right. How did that impact? And the thing about science is that when you challenge a hypothesis, you need to be able to answer that. And what was their answer when their hypothesis was challenged? I don't think they had one.
Absolutely. And so, what do you think, I know many people that could be watching this will have had some level of psychiatric impact from their Lyme disease, especially, as what's recognized as medical abuse syndrome, or, where I think I have medical PTSD. Like, I avoid doctors now after all my experiences. And I actually, even as a former clinical nurse specialist in critical care, I get paranoid in the doctor's office. Like, I'd have flashbacks or something. I don't know. I
Well,
turn into a 5-year-old.
I'd like to address that for a minute. I think, first of all, let's look at what happens. Let's say I come down with Lyme disease tomorrow. When I did my study where I looked at 100 patients who had clearly, CDC criteria Lyme disease, and I assessed them before and after. Before, they had an average of 4 symptoms. After, they had an average of 82 symptoms. Okay, so now if you get that, you have all these things going wrong with your body and your brain and your cognitive abilities and the fatigue and everything. So it's hard for you to believe it. And the other thing is that you don't look sick, it's not like you have scar tissue or broken arms that are apparent. And then other people around you, it's hard for them to believe. And then it's hard for many doctors to believe. It's hard for bureaucracies to believe, and insurance companies, if they do believe it, they don't want to say they believe it. Although when you apply for disability policy, they believe it. But when you're applying for a claim, they say they don't believe it. So that's, it's hard to grasp. How could this, Dr. Fallon once described it, comparing the story of Job. It's like, how can all this go wrong with me? And it's hard to comprehend it, but it really happens. But that's how this occurs. And so that's traumatic. And if you look at what trauma is, and I did do a talk recently on trauma, post-trauma, and immune disorders, and what the link was. I also see that a lot of Lyme patients get inflammation in the temporal lobe that gives intrusive symptoms. And that's a hallmark of post-traumatic stress disorder. So there's something about the physiology of Lyme disease that gives a PTSD, post-traumatic stress disorder, like encephalopathy. And so there's a physiology causing that, even with someone who hasn't had trauma. So, but then if you have trauma and you have a brain condition that alters your brain physiology, that makes you more prone to some of the vulnerabilities, the risk factors for PTSD, you have both of those things added together. And then that's part of the vicious cycle that keeps someone sick. Because then if they have the trauma and they have the nightmares and the intrusive symptoms and they're hypervigilant, then it's hard for them to relax and heal. And it's a vicious cycle. And when I assess a patient, and as I said, there's 80, and some patients have a lot more symptoms than that. Where do you start? Where do you treat? And I think the trick is you have to look at how all these things fit together and go after the more critical symptom first, that keeps someone more in a state where disease is progressing and perpetuating, and intervene there, and then work your way down the list. And from a psych standpoint, that's often looking at the non-restorative sleep or the psych symptoms that impair, be it the anxiety, depression. Some people turn to substance use or whatever the symptom may be, and work your way down the list. So you're looking at treat the symptoms, tweaking the immune system, and addressing the infection, those 3 basic areas. But also education, so people understand how this happens. And it all makes perfect sense. It can seem overwhelming, but if you understand the mechanisms of how these things work, it's predictable. It makes perfect sense.
Thank you, Dr. Bransfield. And I wanted to touch on how we could possibly impact the, all in your head aspect of what many Lyme patients around the world, and particularly in Australia, face. I know a different patient that I've been helping for many years now has recently had a setback, and she's lost her Lyme treating doctor, which almost all of them are shut down in Australia. And so she doesn't have access to treatment, which was keeping her above board, but now she's sort of regressed into psychosis, and she's been scheduled in 5 different hospitals in the same region. I've been helping her each time. I haven't been able to get one psych registrar, one psychiatrist to look at the potential for her past. She had 9 positive tick-borne diseases. She's had, they call her seizures non-epileptiform seizures, which then gets a label of functional, which then leads down the psychiatric path. And she's scheduled, and she does do a little better with some antipsychotics, but they won't look at that it's secondary to infection at all. They're completely closed, no matter how many I've given them your studies. If anybody will talk to me, and most of them just dismiss me when I'm trying to advocate for her. What do you see a route or a pathway to make a change on that?
Well, for instance, first of all, the seizures, I'll address that. That's a smaller issue. That was controversial when I was a medical student. And just because you don't prove it on an EEG doesn't mean there isn't seizure activity. And a lot of Lyme patients do have these partial seizures. Now, in one case, they opened up the brain and put an electrode deep in the limbic system, and then they picked up seizure activity that wasn't able to be detected on the surface of the brain.
Yeah.
I wouldn't do that with every patient, but I think in a research way, you can show that a lot of times the seizure activity doesn't get to the surface of the brain. And sometimes nasopharyngeal leads, sometimes sleep studies, but it often doesn't pick it up. However, by their description, it seems seizure-like, even though you don't prove it with your run-of-the-mill EEG. But when you give these people anticonvulsant meds, it goes away. So I think that is rather strong proof. I did an article in 1999 about this with a patient and treated her with anticonvulsants, and she was treated with antibiotics, and now she doesn't have these seizures anymore. And now the other, it's a matter of them expanding their thought, and that what you don't want to do, and I think it's a mistake a lot of people here in the United States make, is they do the surveillance criteria testing, and it's negative, and they say we don't have Lyme disease. And really, it's 50% reliable, but in late stage disease, it's never been standardized. So, and Lyme is just really a marker for complex tick-borne disease. So I think it's probably overwhelming. Now, the antipsychotic meds, they do help because you treat the symptoms, but you're not addressing the cause. And if we look at our ICD-11 or our DSM-5-TR, it categorizes mental illnesses, but it doesn't address the causality of how these mental illnesses come about. And to think of psychogenic, it's like psychogenic, it's the idea that if you have a clotting disorder or an arrhythmia or broken bone, that's objective, that's physical. But psychiatric just come from nowheres. They come from a vacuum, and that's absurd. Everything's caused by something. And crazy is what we don't understand, okay? Once we understand it, it's no longer crazy. It makes perfect sense. And there's certainly been enough cases. In some of these cases, we're looking at Bartonella and Babesia and these other infections. And invariably, they're complicated. They're complex interactive infections. They're not just one infection. And so we do see that these people may improve from antibiotic treatments. And that tells us something, but it's overwhelming, I think, for some doctors to kind of think outside what they've been trained, can they educate themselves to new ideas? And if I only stayed with what I was taught in medical school, which is now 50 years ago, I graduated, where would it be today, right? Particularly in psychiatry, the field of psychiatry has changed a lot in 50 years. And we have to be open to new ideas, but I think it's overwhelming for maybe some people to consider this, but I think it's encouraging to think you could be more effective when you think of a component that you never considered before. Mm-hmm. That's an additional way of treating someone. Now, I think once someone's been sick for a long time and have been psychotic for a long time, then it's hard to undo it. But if it's a recent onset psychosis, it's easier to turn it around. Some of this research was schizophrenia involved toxoplasmosis. and owning a cat and cat-borne disease, although cats also carry Bartonella. So people that own cats are more likely to have psychotic illness. And that study, and we see through toxoplasmosis, it correlates with a greater risk of homicide, suicide, and auto accidents, and schizophrenia. But there's many, many infectious disease models like that that correlate with mental illness. It's, I guess some people forgot about syphilis, that once penicillin came out, people forgot that infections can cause mental illness. And with the onset of penicillin, people thought that the whole infectious disease epidemic was conquered. And now we no longer have to think about that, but that's incorrect. So I don't know what it takes for some people to be open-minded, but I think it's an, you don't want to get defensive. You know, it's an opportunity to open new doors to help people in ways that you never helped people before. So why not be open to that? And now the all in your head, you know, that's just a way of, I think, washing your hands of it, of not trying to figure it out. It's, you know, if someone's, are they reacting? Are they overreacting? And why would they suddenly be overreacting at this point in their life when they weren't before? Like I say, these things are not being hypochondriacal or psychosomatic isn't something that begins suddenly at one point in a person's life. They would be there lifelong, right?
Yeah, no, I get it. And I think this is going to be really helpful for people. So, you know, on the topic of doctors, you know, looking deeply, you know, obviously we would like to acknowledge that the bureaucratic and the regulatory situation in Australia is hostile to doctors who are free thinkers or innovative in their approach. But we hope that, you know, as patient groups, we'll continue to work and make sure we get that turned around. So I also wanted to, you know, we do want to be cognizant of people who are quite sick, how long that they can focus. But I'd like, could you comment on persistence and the additional challenge that the question about persistence brings to this topic of Lyme and mental illness?
Okay, well, a lot of, you know, the one thought can be, you may get an infection that's a hit and run infection, and it causes injury, and then it's done. And now that injury is there, it affects that adaptive circuit, and now you have a residual from it, and that's it. And then you can have chronic relapsing, you can have a chronic infection that's there at a low grade that may be persistent, or it may be relapsing periodically. A good example of that may be shingles with chickenpox. So you get shingles when you're in third grade, and then when you're 80 years old and you get cancer, then you get shingles appear. Now it was there the whole time, but your intact immune system kept it in check. So what happens a lot is we get these infections, an intact immune system may keep it in check, but then when we're under stress, we may be immunocompromised, and then it comes back. So persistence and trying to prove that it's gone, it would be like me taking a test tube and going down to the ocean, putting it in the water, and then looking and saying, well, there's no bacteria in the ocean because I couldn't find it in this test tube. How do you test? All right, where do you look? Now, the most reliable, the gold standard really is autopsies, right? But a lot of these pathogens that we're dealing with in the microbiome, and we have 10 times as many microbes in our body as human cells, many of which have never been identified. And many tick-borne diseases have never been identified. When you look at tick microbiome, and some people do, like at Drexel University, they find this huge number of infections that are in ticks. So, and they can be different in different areas. So when you get a tick bite, you get this significant number of potential pathogens. Now, some may not be pathogenic, but some are. And they can be there and they can be chronic. And then what can happen is with some, we recognize they're immunosuppressant. Now, Borrelia has been around for millions of years. We found it in agar in the Dominican Republic, and we find it in mummies. So when it's been around that long, it knows how to survive. And so it's great at surviving, and it can survive in host of many different hosts. So we know it has a persistent ability, and we've proven it with autopsies of people that have been treated and been on IV for months and months and months, and we still find it in brain tissue. So we know it is persistent. There are about 80 articles supporting persistence of Borrelia infections in people. And using testing that's flawed, particularly immune-based testing, because it's able to suppress the immune system, and that's how it can survive. And then when it suppresses the immune system, it activates opportunistic infections, like viral infections. So when you get Lyme and different tick-borne diseases, you never know what you're getting. And then you get immunosuppression, and then you get activation of these opportunistic co-infections. So you see the viral titers go up. And then you treat the Lyme, and the viral titers drop. Now, when we think of a tick-borne infection, if I'll do an experiment, and to someone who's a skeptic, if they're a skeptic, we could do this. I'll go out with a syringe and I'll take blood from snake, lizard, rats, mice, deer, I guess kangaroo if it's Australia, and koala bears, okay, and you know, and birds and everything I can find, chipmunks, squirrels, and then I'll inject it into someone who's a skeptic. And I say, let's see what happens, okay? Now, what's in that blood? Now, that's what happens when you get a tick bite, right? It's nature's dirty needle. It's a cesspool of pathogens, many of which are not identified. So when you get bit by a tick, where's that tick been, okay? Had that, you know, or what pathogens are there? We don't know. So that's part of why we have to have humility, is our ability to identify all the pathogens that can be in tick-borne diseases is very limited. And to think that there's no pathogens that are in ticks, you know, that would have an effect on chronic health is beyond comprehension. It goes beyond logic. And so I think a lot of these chronic infections, now when we think of chronic infections, we think of three basic things: viruses, venereal disease, and vector-borne disease. So viruses can be chronic in the body. Shingles or herpes virus are examples. Venereal diseases can be chronic, but so can vector-borne disease. So vector-borne diseases aren't just tick, they're louse, they're spiders, they're mosquitoes, and they go from animal to humans. We could think of Ebola, anthrax, Zika, malaria as examples. So, but ticks do their share of damage and carry their share of diseases. So we recognize mosquitoes carrying disease. We recognize these other vectors. Why not recognize ticks also as carrying a large host of disease, some of which have not been fully identified and studied adequately yet? And they're often quite regional, but they're not as regional as you might think, because birds carry ticks from one area to the next. And for instance, in America, we get the European strain of Lyme disease, and from people that have never been in Europe. Why would they get that? So, you know, these birds are not necessarily loyal to one country. They can fly thousands of miles, and there's birds in Australia. Where have they been, right? And they migrate, and they carry ticks with them, and the ticks carry diseases. And some have looked a lot at looking at songbirds and the different birds, how they carry sometimes multiple ticks with multiple infections, long distances. And so that's a reason to be careful about having a bird feeder in your backyard. That, you'd have the mice and you'd have the birds, and it would create a perfect ecosystem for a tick-borne infection. So it's very complicated, and to be so negative and persistence, there have been too many autopsy studies. There have been a large number of studies showing that there's been persistent with treatment that was considered to be sufficient. So that's inaccurate scientifically. You can't say there's a lack of persistence. you can only say that it's suppressed temporarily. And I've had patients where they're treated, they're okay for 10 years, they have an auto accident, and then they get a relapse and a reactivation because you don't have adaptive immunity to this. There is no adaptive immunity. So that's why, you know, it's outrageous to say that it can't persist.
Thank you, Dr. Bransfield. And, I know that this is an immense topic and we could go for hours. I could go for hours anyway, but I'd like to complete with some thoughts on the DISCAT clinical pathway, because you gave a very solid quote for us in that pathway in regards to ensuring that you'll make yourself available to be a witness in court to the Australian government for crimes against humanity. And I can only back that. You know, their DISCAT clinical pathway is an abject failure of their responsibility to sick Australians. And they've been shown proof of illness and shown proof of causation in Australia, and they've denied taking action. And currently we're pre-election right now, federal election in Australia. And the four major parties have declined to make any definitive statement of real action for Lyme patients in leading up to the election. So if they don't do that pre-election, I'm not too hopeful for what happens afterwards. So what would you like to say to people with your commitment to ongoing support for Lyme patients in Australia?
Well, what I've seen, and I've seen it take place here, is once a politician becomes infected, and it's happened with a number of high-ranking politicians, not all of which let it be known, a couple did, and their family members. Once that happened, then they suddenly have an awareness to it and a motivation. And that's what happened with the AIDS epidemic, where once it affected Hollywood people, then there was support. So once it strikes home, it's no longer an abstract concept that there isn't sufficient proof of. The proof is looking at yourself or your family member.
Yeah.
Now, I like when you fail to treat this, like I see the tragedies from failure to treat. So I can see young people that are disabled their whole life who would have otherwise been productive. I see people tortured by anxiety, depression. I see people that turn to substance use. I see people who get these infections and then become violent. And then I evaluate these people after they've killed someone. And when I look at that, and it might be on death row or some other penal facility, and someone missed the diagnosis, or they didn't give adequate treatment, or when the treatment they gave, we'll say, well, it was a month, it should have been enough. Yeah, but my symptoms are relapsing. Yeah, but that should have been enough. So this is psychogenic. Yeah, it's psychogenic. But then they went on and it got worse and it deteriorated, and then they committed murders, or they committed suicide, and that could be prevented. Isn't there a motivation to want to prevent all this harm that is being done to society? We can improve the quality of life. We can prevent some mental illnesses, or reduce the severity of it. We can reduce a certain amount of aggressive or criminal behavior. We can reduce suicide, self-harm. Why don't we grab at that opportunity to improve on the world? Why get hung up with, well, maybe there's not quite enough evidence? Then learn it, study it, sit down and look at it and try to figure it out and try to connect the dots. We have too many people that don't connect the dots. When you connect the dots, it's obvious, but you have to go outside your silo to connect the dots.
Thank you, Dr. Bransfield. And I'll just end with a quote here from you, that unfortunately patients cannot put their chronic illness on hold until the medical scientists come to a consensus on whether the evidence suggesting infectious causation is or is not close to definitive. Making wise decisions in an uncertain scientific environment requires balanced reasoning, critical thinking, compassion, and common sense. What would you like to leave Australian Lyme patients with today, Dr.
Right. When you're on the front line as a doctor, you have to treat someone today. You can say, well, there's a study and it'll take a couple years to recruit people, and then we have to analyze the data, and then come back in 5-10 years and we'll see what that shows. And medicine never has perfect knowledge. It never has perfect consensus. We use what's called evidence-based medicine, which sometimes is taken out of proper context. And evidence-based medicine is the best evidence available, and it's never perfect. And then you have to look at clinical judgment, which is a big part of it, individualizing it for that patient in front of you. Because when we do a study, we do it on other people, we don't do it on you. And how much is that study relevant to you, to the patient in front of me? And then patient preference, where patients say, well, I don't want this side effect, or this other side effect might be more okay. So it's a combination of those three things. That's how you practice medicine. That's evidence-based medicine. And that also is Canadian, by the way, that he's, and I think that's a good way to look at it. And that's how we have to look at it, and not look at this needing absolute proof, and more of an ivory tower academia. And that's what we do in academia, where you're looking at absolute proof. But academia isn't the way that you treat clinical medicine in everyday practice, where you have to treat someone today with the best that you've got today.
Dr. Bransfield, God bless you. Thank you very much. And Lyme Patients of Australia, we're not stopping. We hope you have a good month of May as you can. And Professor Bransfield, maybe we'll meet again in the future and we'll do another one of these. Oh, we should comment that there's a continuing medical education course coming out. And when we host this on our website, we'll put the link to that so that we can spread the word around Australia. So thank you for all you do for all Lyme patients globally.
All right, thank you, Catherine. And yeah, I'm glad I traveled there to Australia and Austria and other countries. And I see the same thing, same issues in other countries, and some places are further along with this than others. But it really is a global epidemic that we need to tackle. And hopefully we've learned from COVID, because it's a lot of carryover with what we've seen. So
Absolutely.
don't
Very
give up the
parallel,
hope.
isn't
I
it?
think there's a lot we can do to help, and eventually knowledge will prevail.
Thank you.
Thanks.